because of
Okay.
confidentiality. So I will remind you about that one.
Okay.
Yeah. So so we have put together a good amount of information about who we are, what we do, and how we work together with all of you in our multidisciplinary team. So we're gonna give you a little bit of an outline what the day is going, what the afternoon will be about. We will talk a little bit about an introduction about what our work in perinatal and peri-infant psychotherapy. Danny will be sharing some reflections on perinatal psychotherapy over the years. Then we will talk a little bit about specifics of peri-infant psychotherapy. And Mel will be bringing some of the theory alive with two cases. Hopefully we will get a chance to go through the two cases, and there will be times for questions and reflection and discussion. So Danny, it's up to you. I'll pass it to you.
Okay. Can you hear me okay? Does
Yes.
this work? This headset work okay? Yeah, good. So it's okay. Thank you. Right. Yeah, I'm going to deliver my reflections on, for my part of this presentation, my reflections on perinatal, peri-infant psychotherapy, kind of the way I've seen it evolve in my work and within the team over the years. And I hope that's a good lead in then to Mel delivering her case and other reflections, and anything obviously at the end you all want to kind of feedback to us or debate or discuss or whatever. But so the beginning part is really just my kind of perspective on how I think things operate within the psychotherapy room, okay, with these so often very complex cases that we all see. So I will just go over to my writing here. So it's reflections on perinatal psychotherapy, stroke parent-infant psychotherapy. So for those of you who don't know me, I'm Danny O'Shea, perinatal and parent-infant psychotherapist within the Wandsworth Perinatal Service. And I work alongside Melanie Roll-Lawson and Karina Sarmiento, who will be delivering their reflections as well after I finish my segment. So the PIP team, as we are commonly referred to within the Wandsworth service, has a long history dating back to the 1990s with its origins in CAMS, a CAMS perinatal mental health service formerly based in Chelsea and Westminster Hospital. And that was the first CAMS, as far as I'm aware, the first CAMS perinatal service in Europe. That was way back in 1995. The PIP team is now very much part of a multidisciplinary Wandsworth perinatal service, and we acknowledge that we and our patients are well supported by our colleagues in the Wandsworth service, and we really do appreciate that. So we do feel very much part of a multidisciplinary team. Between the three of us, the psychotherapists, our psychoanalytic psychotherapy training in child and adolescent psychotherapy, perinatal psychotherapy, and adult psychotherapy has enabled the team over many years to direct a psychotherapeutic spotlight on the care and development of babies, children, adolescents, young adults, and parents. In relation to my part of today's presentation, I'd like to set out the framework that I'm considering psychotherapy from. I'm approaching this from a point of view of pre-pandemic and prior to the mass introduction of media platforms as a way of carrying out psychotherapy sessions. Discussion around new ways of providing psychotherapy would be a topic for another day, I feel. So I'm approaching this presentation from the more traditional way of thinking about face-to-face perinatal psychotherapy, that is within a consulting room. I'm also going to be somewhat fluid in the use of the terms mother-baby and parent-infant. Overwhelmingly, over the many years I've been involved in this work, it's been the mother and baby that I've seen together, as it's been typically the mother who's been referred into the service, so the index patient generally. That's not to say I haven't worked with fathers also, but that would be less typical, and I recognise that there are a range of main caregivers to babies in contemporary society. Essentially, I feel using the term mother-baby psychotherapy better fits with my practice because this is the couple that has predominantly entered into the consulting room. Of course, I and my colleagues in the Wandsworth Perinatal Psychotherapy Service have also adapted to working in settings in the community, such as GP surgeries, children's centres, and the homes of patients. So there has been some flexibility in the setting for psychotherapy sessions when needed. And I just think now it comes into my mind when I've sat around the kitchen table on a number of times doing psychotherapy with patients in their homes. I would say the kitchen table comes to mind very distinctly with one particular patient, and it's certainly a change of setting, and it does provide challenges. But I think it's a very powerful experience to take psychotherapy into someone's home when it works well. So, and because we often work with patients during the pregnancy and the early months post-birth, I personally lean towards the term perinatal psychotherapy as opposed to parent-infant. But I do recognise that PIP, that's parent-infant psychotherapy, is a more catchy and popular term these days, and is indeed now a training in its own right. It certainly is early intervention and preventative work, and has a clear intent to help prevent the possibilities of the baby growing into a child, adolescent, and adult needing a referral to CAMHS and/or adult mental health services. Through my training at the Tavistock Clinic and my clinical practice, I increasingly appreciated the theories and concepts of Sigmund Freud, Wilfred Bion, Ronald Fairbairn, and many other psychoanalysts from the past and their approach to understanding human experience. Alongside that training came hand in hand my own experience of laying on the psychoanalytic couch and the training requirement to be in analysis a minimum of 4 times per week over several years. However, working within the modern day NHS as a psychotherapist and often in settings within the community, trying to apply psychoanalytic thinking to the work has its challenges. A very basic example is that a significant question might have been posed to a mother in a session just when the baby requires a nappy change. Kind of two things coincide, and they have to depart together to the mother and baby changing room, which inevitably breaks the dialogue. So a flexible approach to this work is essential within the perinatal version of psychoanalytic psychotherapy. As the months are counting down towards my full retirement from this work in the NHS, I've reflected on what really depicts psychotherapy within the perinatal field. And for me, there's not a clear-cut answer. But put simply, perinatal psychoanalytic psychotherapy sets out to develop and strengthen the mother-baby relationship in its earliest stages. And this is rooted in the psychological and emotional dialogue that takes place within the patient-therapist relationship. Absolutely key. There are some fundamental concepts and ways of working in psychoanalytic psychotherapy, which I will come back to, or we will cover later. But for example, or will actually be on the slides regarding transference, the unconscious, etc. You might come to those slides later. But for example, the delivery of psychotherapy will vary between psychotherapists, not only in terms of their training backgrounds and their individual style of working, but also because each patient and mother-baby couple is different and unique, despite there often being some similarities in how they present in the consulting room. So I remain mindful that different psychotherapists might provide different reflections about this work with patients, but Mel, Karina, and I all start from the same basis of being therapists with a psychoanalytic orientation. In my view, there is one psychoanalytic great who was the most attuned to the work with mothers and babies, and that was Dr. Donald Winnicott. For me, Winnicott's approach to the clinical work with parent and infant is one I would lean towards and relate to most in my experience of perinatal mothers and babies. I would immediately direct any interested party to some of the key facets of Winnicott's experience, approach, and concepts, including what he refers to as the good enough mother, the facilitating environment, and the false self. Winnicott's idea that there is no such thing as a baby is what resonates most of all with my experience of psychotherapy with the mother-baby dyads. What Winnicott was getting at was that the natural dependency of a baby necessitates there to be a relationship or a fusion between the baby and their primary caregiver. And entwined in that is the caregiver's emotional reactions and communications towards the baby. Understandably, many of the patients we all see, all of us, this service, in our clinics, are on pain-filled journeys with their babies. Key task of the psychotherapist is to try and bring relief from the pain through a meaningful psychological encounter and not leave the mother and baby adrift with all the pain, such as an emotional disconnect. And I saw one of our patients today where there is absolutely 6 months on, no feelings towards the baby, really could take her or leave her. So it is really, as we all know in this service, it's really tough work. The importance of this particular model of psychotherapeutic work with the mother and baby couple has been highly evident in the consulting room over the years of my clinical practice, because babies are always welcomed. In fact, mothers are encouraged to bring their baby with them into the therapy sessions. However, I've also become very aware of the significance of the mother's state of mind as being central to the growth of her baby's state of mind. I would draw on Winnicott's concept and discussion around no such thing as a baby in cases I've seen where the mother is in a total psychological crisis. And what I mean by this is that the baby can struggle to thrive in such a context, when in particular the mother is unable, because of her unwell state of mind, to properly receive her baby, just like the patient this morning. This is where it's important for the therapist to try and help take some of the psychological burden off the mother experiencing crisis and trauma, and in turn help the baby have less of a struggle finding an emotional attachment with their mother. And in the end, I do think what we're doing, all of us even might have slightly different approaches. I think we're trying to take the burden off the baby. Within perinatal psychotherapy, as in any psychotherapy, there's a psychological relationship between a couple. That is, between the patient and therapist. There are other couple relationships, one between the mother and baby, and another between the therapist and baby. The baby in the consulting room with the parent and therapist, of course, introduces another dimension to the dynamic structure of a clinical session. So there is a triangular relationship building between the mother, baby, and therapist. At this point, I'd like to refer to how psychoanalyst Adam Phillips, worth a read, Adam Phillips, describes in his own words Winnicott's approach to couples within the psychotherapeutic process. He says, and I quote, It is important that we don't read Winnicott too literally. Don't assume that when he is talking about mothers and infants, as he almost always is, that is all he is talking about. It is as though Winnicott realized that talking about mothers and babies was a way of saying things about couples that he wouldn't otherwise have been able to say. It is not that Winnicott isn't really talking about mothers and babies. but that he is also using mothers and babies to talk about other things as well, both sexuality and a person's relationship with themselves. I think it's noteworthy that Phillips mentions the individual's own relationship to themselves, not least noteworthy the realm of when considering the enormity of life change involved when becoming a parent. Parenthood, particularly motherhood, is one of the most common and powerful developmental transformations to negotiate in adulthood. With the majority of patients I've met, there have typically been complex and difficult past histories to the mother's own childhood and adolescence, which have aroused further psychological problems during the transitions into parenthood. Many have also experienced trauma within the experience of giving birth and put it all together, and there can be a melting pot of complicated thoughts and feelings that the patient brings into the consulting room, hoping to find some resolution. From my perspective, the psychotherapist has to attend to the psychological disturbance in the adult, whilst keeping a firm eye on whether the relationship between mother and baby is forming a healthy connection. The highly subjective experiences, narratives, and past family contexts of the patient require the psychotherapist to try and bring some understanding in the present day, and by doing so, negative patterns of functioning in the past might be modified to facilitate positive steps forward. This is from a patient from 2016. At the end of her treatment, a former patient described her psychotherapeutic journey. She commented, "Psychotherapy gave me time, space, and compassion, and in this enabled me to see the past for what it was, to feel love and loss for the child within me, and to recognize that whilst she is an integral part of me, a part that I can acknowledge and I should have loved, she is not a part that defines me, nor whose fear calls the shots any longer." And that was from Laura in 2016. Also, traumatic experiences in the mother's recent or more distant past can result in them losing a sense of connection between their imagined baby and their live baby. It can be incredibly difficult to see other people happy with their babies when a mother has been left feeling lost and wanting to close off from the outside world after becoming pregnant or having their baby. It is not uncommon for the parents that we see to have experienced traumatic events in their lives, such as their baby being hospitalized with serious medical conditions and medical emergencies. The impact of this type of trauma cannot be underestimated within the building of a psychotherapeutic relationship, and it is like a scaffold going up, I think. The sharing of and offloading of their experiences can be part of a recuperation process. In many cases, the mother will offload, often vent their thoughts and feelings session after session. And it's the role of the psychotherapist to stay with it and find the right moments to help bring about some form of productive change. Such patients often notice that they feel angry and/or despairing about the same things, on repeat mode, as one mother put it to me. But in many cases, they have to be repetitive until there is the right opening for psychological change. And I think Freud would refer to this as working through. He would have said that this repetition does have to happen, I think, in the therapy room. An advantage to a longer term intervention is giving a patient who is affected by traumatic events the time to reach turning points and self-realizations that can emerge during the course of a psychotherapeutic treatment. A light bulb going on, as a patient once described it. A light bulb moment she's talked about. The self-realization moments are often growth moments in the psychotherapy, representative of some evolution from feelings such as vulnerability and insecurity to more independent self-understanding. And of course, light bulb moments can happen not necessarily just in the sessions, they can happen outside of the sessions, in between sessions. I don't know, putting the plates in the dishwasher or whatever, someone can have a light bulb moment. Something switches on about something that's happened within the psychotherapy that helps fit together. As many of the patients we see in perinatal psychotherapy are experiencing the absence of an internalized good object, or in Bion's terms, the absence of a container, when they are tormented by persecutory thoughts and feelings, they will often deposit their unwanted feelings into their therapist. To be a steady external container for the patient's worst thoughts and feelings is, for me, one of the most central tasks within a psychotherapeutic relationship. When the mothers that we see are caught up in their own web of subjective experiences, both from the past and present, the therapist has the potential to receive their projections and then try and make sense of what he or she has received. In relation to the way the patient might use the psychotherapist in sessions, I hope I get the pronunciation right, Stanley Ruszczynski states, he's a fantastic couple therapist from the Tavistock and Portman, amazing guy. And he states, through the work of John Steiner and others, we have learned to respect the difference between a patient being understood by their therapist and the patient understanding themselves. Understanding oneself requires a capacity to take in experiences that by definition for these patients feel to be unbearable, which is why they are projected externally. As a result, a necessary aspect of our clinical role is to allow patients to use our minds and our bodies to deposit that which they fear, whilst they watch and observe how we process and manage that. However crucial the content of interpretations may be, these patients do, in addition, need this experience of borrowing our minds, sometimes into which to deposit some pretty unpleasant things. And I'm sure we've all experienced this as well. You go home feeling really laden down by the projections. So I'm going to say Stanley's point about patients developing self-understanding within the psychotherapeutic process is extremely important and significant when working with patients who have often lacked opportunities during their development, during their growing up, to engage in emotional dialogues and relationships with others who are able to contain their emotional conflicts and impulses. And again, I'm sure we've all worked with so many patients who really, in one way or another, have experienced so much deprivation psychologically. As mentioned earlier, psychoanalytic psychotherapists undergo several years of being in their own personal analysis as part of their training. This is a very important component. For example, it helps to equip the therapist for being able to be deposited into by the patient and to manage the psychotherapy tools such as transference and many other things, and also to develop an understanding of what it's like to be the recipient of a deeply self-examining process. So, to conclude my segment within this presentation, typically, I would say perinatal psychotherapy treats. So I hope this helps with the huddle as well. We're in the huddle on a Thursday. Typically, psychotherapy, or the psychotherapy that the three of us practice, we're used to treating chronic and intense psychological disorders affecting patients during pregnancy and post-birth. really chronic and intense, and complex attachment problems between the mother and baby. This can sometimes involve working with the parental couple. Ideally, psychotherapy sessions happen, this is the ideal world. Psychotherapy sessions happen at the same time, same day of the week, and in the same room. This is an important aspect of the psychoanalytic psychotherapy model, and it's about maintaining a reliable and consistent environment for both mother and baby. And of course, this has been threatened so much over the last couple of years by the pandemic, and we've had to adapt. In general, patients are seen weekly, and the patients have had to adapt as well. And in general, patients are seen weekly or fortnightly, but some can be seen more frequently or less frequently depending on the seriousness of the case, with each session spanning 50 minutes, 50, therapeutic hour. The psychotherapeutic process within perinatal typically takes between 6 to 18 months. Sometimes it could be shorter, depends what happens, to bring about psychological growth, depending on the complexity and chronic state of an individual case and the timing of the referral made. Psychotherapy sessions, I can't just say, I do think psychotherapy does help in pregnancy. So I think the sooner the referrals happen, the better. Psychotherapy sessions can continue up until 12 months post-birth, but in some exceptions, it may be decided based on patient need and professional judgment that it's in the best interests of the patient and or the baby for psychotherapy treatment to continue beyond this period in order to limit risk and improve outcomes. For example, in complex cases where there are unresolved issues within the parent-infant relationship. So I'm now going to hand over to my colleague, Melanie.
Hi, everyone. Thanks, Danny.
Sure.
Right, bear with me. I'm just bringing up my spiel. So, to help illustrate some of the hidden meaning and aspects of our ways of working, which Danny has just touched upon, and to highlight the importance of the therapeutic relationship, I'm going to share a couple of cases with you, hopefully. These are not current NHS cases and were in fact written up as part of a paper I compiled several years ago on the intergenerational aspects of the mother-daughter relationship. I hope these begin to demonstrate some of the processes of our work and terms that Danny has just referred to. Both cases that I'll share are examples where the complexities of a mother's own childhood experience within her first relationships can impact and manifest themselves on their relationship and experience with their own baby. The cases also, I hope, show how the psychotherapeutic process offers containment and facilitates this idea of self-realization and making the unconscious conscious, which enable individuals to evolve from a position of vulnerability or insecurity to a position of understanding so they can make sense of what's going on and how they are feeling. So the first case that I'm going to talk to you about introduces Kelly and Cora, and I'll just give you a bit of background. So Kelly was referred by her midwife at 10 months postpartum due to having, and this is a quote, a difficult baby to settle and feed. Her baby was experiencing colic and Kelly was depressed with suicidal ideation. And there were concerns that the family were not receiving the support that they required within the NHS. This was pre-rollout of the National Perinatal Services that we work in now. Our work together focused on maternal and paternal, when Dad joined us, ambivalence, the conflict between maternal and baby's needs, and baby being utilised as the family scapegoat. You'll hopefully hear as I read the difficulties and complexities within Kelly's own childhood experiences and relationships with her own mum, and how these got in the way of her developing a healthy, good enough relationship with baby Cora. Our work together looked to enable Cora's parents, specifically her mum, to take back her own projections, allowing and accepting baby Cora as Cora. Negotiating separations for both Kelly and baby Cora was a major theme in our work. And what I will present here is based on our first 15 sessions, from Cora being 10 months to 15 months old. But my actual work with the family continued until Cora was almost 3 years old. And it was a happy ending with Cora, being at the end being more than ready to separate from mum. Kelly and Cora, the demonized baby. My first case draws reference to Freyberg's classic paper, Ghosts in the Nursery, and introduces 35-year-old Kelly, a married mother struggling with her conflicted image of the mother within, and her demon baby, Cora. From my first interactions with Kelly and Cora, it became evident, as Freyberg would have said, that the intruders from the past had taken up residence in the nursery, which I'll come to later. At the time of referral, Kelly was feeling completely overwhelmed by her relationship with her daughter, 10-month-old Cora. Depressed and struggling with suicidal ideation, she described thoughts of jumping out of a window with her baby. Cora was extremely clingy and spent the majority of our early sessions in her mother's lap, which irritated Kelly, who found her inability to let go of her.
Sorry, Mel. Sorry to
Yeah.
interrupt. Sorry.
Yeah.
Jill, did you stop the recording? Is Jill there?
No, I haven't. I didn't realise I was stopping it at this point. I thought this was anonymised. So I need to stop.
Don't worry, I'll just carry on. Don't
Is
worry.
that all right, Mel?
It's fine, don't worry. As long as it's
Okay.
not shared beyond the team.
Okay.
Okay,
Sorry to interrupt.
that's okay. So Cora was extremely clingy and spent the majority of her early sessions in her mother's lap, which irritated Kelly, who found her inability to let go of her infuriatingly suffocating. During our first meeting, I observed Kelly initially trying to sit Cora on the floor in between her legs. But after Cora began to cry, Kelly immediately took her back into her arms. She would seethe, roll her eyes, and talk about Cora's irritating cry, and how everything in the family had been lovely up until they had Cora. She perceived Cora as a demon sent to ruin everything, and nothing like her lovely first child. There appeared to be a theme of intergenerational rejection and abandonment of the daughter by the mother, spanning 3 generations. Kelly described her own mother's fraught relationship with her grandmother, and also recalled her own experience of hastily being sent to boarding school, feeling her mother did not want her getting in the way of her new relationship. Kelly claimed she could never consider sending her elder daughter away, before pausing momentarily and turning to Cora, remarking playfully but with malice, "We might send you to boarding school though." Despite her rebuffs, Kelly clearly cared for her little girl, who was always clean and well dressed, and well-prepared snacks or the breast were readily available. On occasion, Kelly would fondle and make affectionate reference to Cora's curls, which felt a world away from the hostile and broken dyad I would often encounter. Both Kelly and Cora would maintain or relate to their attachment through food. And I recall one session in particular when, after Cora fed Kelly popcorn, she pulled a face of disgust and said, "Thank you. That's kind of you. No more for mummy." It was clear that Kelly was struggling to reconcile fierce feelings of ambivalence towards Cora, and her impulse to reject echoed Kelly's experience with her own mother. Rather than being able to identify with baby Cora's vulnerability, Kelly identified with the aggressor of her past. The pathogenesis of the defense known as identification of the aggressor is anxiety and helplessness before the attackers. Through 6 months of working together, Kelly gradually made a conscious recognition of the parallels between her past familial experience as a child and now as a mother. Kelly had a much older brother and sister from her mother's first marriage, so she, like Cora, was the second daughter who had upset the status quo. She told how her mother had always described her as a really difficult, clingy baby who cried all the time, an absolute nightmare. Her relationship with Cora clearly appeared tainted with the same undertones. Kelly felt genuinely sad and guilty about her ambivalence and lack of empathy and tolerance towards Cora. She told me that while she loved her and did not want her to experience the same unhappiness in life that she had, she found her irritating, partly because she had not bargained on Cora reminding her of herself, specifically the part she disliked. Pines tells us that while consciously a woman is perfectly capable of acknowledging her newborn as a person in her own right, unconsciously she is also experiencing her as carrying aspects of herself and of her psychic life which she regards as being highly desirable or, on the contrary, abhorrent. Kelly's struggle to reconcile fierce feelings of ambivalence towards Cora may emanate from her recognition of herself in Cora. And while her suicidal thoughts may represent an angry attack on the mother-daughter relationship, it may also allude to her attempt to obliterate aspects of herself that she perceived abhorrent and rejected by her own mother. Kelly never challenged her mother's rejection, but Cora clearly tries to maintain a resilience of self, which may explain why she insistently holds on. The following extract depicts how Cora responded to Kelly's unconscious desire to abandon her. Cora remained strikingly close to her mum. At one point, Cora is turning and reaching out for a toy whilst clutching and clinging on tightly to her mum's top with her other fist. It is as if Cora is saying that she really wants to explore these toys, but at the same time saying, "Don't you dare move, Mummy. I'm not ready to let go yet." Cora's pseudo-attachment through physicality and proximity lie in the difficulty in being able to emotionally attach and highlight that she has not yet had enough of her mum in order to physically let go. Mariotti describes perfectly what I observed about Kelly and Cora's relationship. A mother may be stuck in a symbiotic fusion with her child, dominated by unyielding projective identification. This leads her to seeing the child as part of herself, with desired or feared characteristics of her own and not belonging to the child. The real individual child goes unrecognised and is therefore neglected. Here, the mother who needs a container for her own unbearable psychic contents may use. Her child is a repository for her feelings. Excessive and chaotic projections weaken the sense of individuality in both mother and child, with a resulting pathological symbiosis between the two, which may alternate with the mother rejecting the child as she tries to get away from what she has projected on her. Kelly's neediness activated my care system, and it was important that I did not repeat the familial maternal pattern in our work and reject her. She repeatedly demonstrated her desire to attach in our sessions, longing for something more from a good enough maternal figure than she could take in and digest. The following extract was echoed each time we ended a session. "It's nearly time to go, Cora," I remark. "Oh," Kelly replies as usual. "You really like it here, don't you, Cora?" I comment. "I think you are telling me that you really like it here too, Kelly." "Yes, I really do," Kelly replies. "Cora is really happy here. It's the place where she has really started to come out of herself." Together we explored Kelly's not wanting to let go of me, how painful this was and how it aided our understanding of Cora and her predicament of not wanting to let her mum go. Gradually, the pathological identification with her own mother began to dissolve, and Kelly was able to acknowledge and develop a sense of acceptance of her own ambivalent feelings towards motherhood, and through the relationship with me, seek new models for mothering. Kelly's empathy and identification with both Cora and her younger self enabled her to recognise Cora's needs and be there for her. As Freyberg says, access to childhood pain becomes a powerful deterrent against repetition in parenting. There was a clear shift in the work, from Cora being seen as a demon baby sent to destroy the family, to her being free to move away from Mum without fear and being seen as an ordinary little girl in her own right. My work with Kelly and Cora was positive from the onset, as we formed a strong working alliance. Kelly and Cora's desire and need to be held and attached, alongside my willingness to contain and accept. However, in my next case, if we've got time to use it, that I'll share, it was a different story, where the transference was much more negative, as I was initially treated with suspicion and hostility, which needed to be worked through in order for progress to be made. Her own ghosts and experiences of ambivalence in the intergenerational mother-daughter relationship contributed to a reluctance and real resistance to form a beneficial attachment to me, which often invoked a real sense of irritation in my counter-transference response. But for now, I'm going to hand back to Karina, and I think we're going to have a little pause for a minute before continuing. So, Karina.
Yeah, thanks, Mel. So I just wondering at this stage, as we have been sort of sharing so much our thoughts and our cases, if it would be helpful for the group to share some thoughts or questions or anything that feels that it could actually open up a little bit of discussion, if people feels like.
And if not, we can continue. It's up to you.
Yeah, we just want to go because we are aware that we've been talking for a good amount of time, and we wonder if people wants to share a little bit about what the thoughts were, or but if not, we can actually go on a little bit more, how people feels like. Should we go and continue?
Continue, Karina. We can always can pause again before I go on then maybe and see how people are feeling. Okay,
so then we're moving on from Mel's case and to talk a little bit about parent-infant psychotherapy, what exactly is. So it's a type of psychotherapy that the aims is to promote the parent-infant relationship, and the ultimate goal is to facilitate infant development. And it addresses all sort of different conscious and unconscious factors in the mother-infant relationship. Yeah, we look into what is being said and what it hasn't been said, but we can sense and we can observe in other things. The parent-infant relationship is addressed either directly or via each participant. So we might be working directly or addressing their relationship, or we can be working directly with the baby or addressing directly the mom or the parents if we happen to have a dad around. So the aims could be more parent focused, or it could be more infant focused. When we talk about being more focused on the parents, if we have mom and dad or mom there or the carer, we will be promoting reflective functioning, meaning helping the parents to reflect on their state of mind and to be curious and to think in terms of what might be the experience for the baby, in terms of what sort of thoughts or feelings or intentions the baby may have. Also to reflect in their own how the state of mind for those moms that, for example, we see in our service, those who are deeply depressed and they're withdrawn, or those who are incredibly anxious, how being in that state of mind affects them in their capacity to see what might be going on for the baby. Perhaps at those moments where they feel very much preoccupied in their own minds with their own thoughts, the baby drops out of their mind. They cannot see, they cannot hear what might be going on for the baby, and the baby's being left in there without no attention. So all the other aims that we work towards, it's helping parents to regulate their own emotions and the infants, not only to soothe and to restore the sense of safety and calmness in the infants, but also in themselves. Yeah. And that is being done sometimes with what Danny had mentioned, and what it was very well put into a case by Mel, by containing what it feels unbearable for the parents. Then we have to enable the parents to recognize the infant as a dependent person with a developing mind. And we try to identify it and to work and to intervene when we feel that there is a repetition of a negative pattern that is coming from another generation, from grandparents to parents to parents to this generation, and to somehow minimize the impact of what can actually come across as a trauma. We also facilitate the couple's parenting of the infant, how we will be perhaps addressing the couple as a couple, how they could co-parent. When the parent infant could be more infant focused, so we will be working into promoting the attachment of the babies to their parents, to promote the baby's coherent sense of self, to facilitate the age-appropriate dependency and move towards separation. And that's what perhaps the therapy is so crucial when moms go back to work, because it's when mom and babies are coming apart physically. There are all the separations that happen prior to that, but I think that's the one that could actually support the diet to move into a different developmental stage, where baby has the capacity to be okay away from mom, and then mom can actually facilitate that transition for the baby. And to assess and address the risks. So we always keeping an eye what might be the risk for the baby, for his development or for his safety, and what can be put in place for the baby to minimize this. And one of the things that sometimes we do is to bring the dad into the picture and to invite dad. So when mom is so deeply depressed or too anxious, dad can be there for the baby and to attend to the baby's needs, and more importantly, to the emotional needs. The parent-infant psychotherapy, as you may know, involves is a collaborative process between the therapist, the mom, and the baby. The baby has a very active role in our therapies. The babies are addressed in our therapist, and if it's not physically the baby being there, it will be work through the maternal state of mind, by the representation of the baby in the mom's mind. The therapeutic alliance is how the parents engage the diet in the therapeutic process, and the relationship of trust that is built in that process, and the importance of this for the success of the treatment. Well, success is not the right word, but for the treatment to have a more effective effect. It is important to remark the therapist's capacity to observe and reflect, we're there to unpack, to look into what it has been said, what it hasn't been said, to perhaps to look into our emotional response during the process of being there with the mom and the baby, because that could actually inform us of what we call the countertransfer, which might be, informs us of the experience of the mom or the baby, the emotional experience. And that's what we call the countertransference. Attention and identification. This is a very interesting topic in here, because our attention can easily go from one side to the other. We can actually be talking to my mom but paying attention to the baby, or to look into the relationship whilst the dad is present in there. So it's how the attention of the therapist has to go, might be shifting from one side to the other, and to be addressing different things at different times. and how perhaps the capacity of the therapist to be able to notice when perhaps we feel identified either with the baby or the mom, would allows us to be in a position of reflect on that together with the mom and the baby in there. Something about, I just wanted to mention something about, sorry, I'm just thinking about the next topic is directly engaging with baby, scaffolding, mentalizing, and emotional regulation. I think we're familiar with this concept. I think we're trying to acknowledge the feelings of each members of the family and also directly engaging with the baby to scaffold his communications and represent this to the mom or the father if he's present. And these techniques supports the beginning of mentalizing and emotional regulation. It might be the actual words that we use when we talk to the baby may have very, little meaning to the baby, but our voice, our facial expressions, and the way that we express empathy and interest will have an impression on the baby. The capacity for change can be seen to occur when mom and baby begin to engage with new ways of thinking about the problem through their engagement with the therapy. This involves mother learning new ways of seeing herself and her baby. This capacity for change will need to be translated to the interactions between mother and her baby, like in Mel's case of Kelly and Cora, which she just presented, where Kelly recognized through her therapy that something was being attributed to baby Cora that actually belonged to an early troubled relationship, and learning to respond to Cora and her needs without resentment, but with genuine care. This is a poem that a patient of Mel wrote right after one of the sessions, if I'm right, Mel. Perhaps you would like to share a little bit about what were the context of the poem, and perhaps you can read through.
Yeah, the reason we've put this here is because you may remember, thinking back to what Danny was talking about, he shared often about how a patient at times might have a light bulb moment in a session, when suddenly things make sense. It suddenly comes to them that they're understanding why something has been happening, or they've been behaving, feeling, whatever it is, in a particular way. It suddenly comes to them, the understanding. This poem was written after a session with one of my patients, after she experienced one of those light bulb moments. So I'm going to read you the poem, because this is obviously from her own words. Okay, it's called Every Day. It wasn't that immediate rush. That's what I was told would happen. It didn't happen like that. Not in a rush anyway, but in a love that has grown, cultivated, multiplied, intensified over time. I have learned to love you just as we have learned to grow together. And it wasn't always easy, but every day we get better at it. Every day we learn. Some days we cry together, but every one of my senses is engaged in loving you, because you are part of me now, the missing part I never knew I had lost till it was found. My wants for the future, my joy for the present, the start of new stories made from the hopes of old ones. And some days I will mourn for the person that I was before, and others I will cheer for the person I have become, the person you created as I created you. And every day won't be easy. We know that. There is still growing to be done. And that is who we are now, moulding each other and loving each other through all our adventures, every day, always.
Thank you, Mel. just wonder how people are feeling at the moment, where they are. This is a good point for us perhaps to have a little time for questions or thoughts or anything that comes up to you. I cannot see anyone because I have the presentation opened. There we go. Where people are in terms of
we just thought we'd give you a little space, a little breather in case you did want to ask any questions at this point or share any thoughts.
Hi, it's Janet.
Hi, Janet.
Hi. I was thinking that poem, that is very much how quite a few of the mums do feel or do express to me that that's kind of not what they were expecting, that they were kind of told, or the media portrayed like you're going to have this burst of love, and they feel awful because they don't feel it straight away, and it's crippling for them because they feel like they're not doing something right, or but yeah, that's really, really common. That really resonated with me, how common that is, and they should read that poem to mums to be, so that they have a little bit, because I think the expectation is so high. It's just so high for mums, and they feel so like they're not doing it right. It's awful. I literally spend a lot of my time reassuring it's just not like they put it in the magazine. So yeah, that touched me.
Thanks, Janet.
That's right.
The mum who wrote that poem, she has had it accepted by Pandas, I want to say. So it's been shared on there, and she's given a permission for our trust to use it as well. So hopefully it will reach some other mums. She's quite keen for that.
I think, as you said, Jan, it will resonate to many mothers, that experience.
I'd like to ask a question. It was just something that Danny said at the beginning about how some of the mums, it might be a little bit of repetition at the beginning. And I just wanted to know, like, do you let them carry on with those thoughts and feelings, or would you try and move them on, if that makes sense?
Hello. Hi.
Hi.
I think sometimes you judge it on. I think you judge it. You judge it on the kind of the progress of the therapy. I think that they are bound to bring quite a lot of repetition at the beginning. I suppose then if it's going on and on and on and on in a really negative way, i.e. it's really holding them back, and you can see that there's a lot of self-destruction around it, then I think you try and obviously kind of bring them out of that self-destructive pattern. But I think repetition is bound to happen because they're in such a dark place often, and they've got to kind of it's I think it's like the digestive system. You have to kind of process it and then expel it. It's got to happen. So but it can go round and round in the digestive system with some of these mums. I think I think you kind of sometimes you sense the moment to say, well, actually, do you realize that you might be banging your head against the same wall every day? Either, I don't know, there are those moments when you think they are really just banging their head against the same wall constantly. So I think you do highlight it at times, but you have to find the moment. From my point of view, you find the moment, and it's got to, you try and make it the right time. But give them a chance to, I think, give them a chance to vent, because often they want to vent and they want to get it out. And I'm sure, again, we've all experienced that, where it's coming at us thick and fast from the patient. But I don't know if that helps answer it at all. Yeah.
No, it does. It does. I was just thinking about sometimes the mums that I've come across as well. It is a lot of repetition. Yeah, and it's sometimes trying to kind of move them on a little bit. But yeah, it's helpful.
And I think, you know, just to add to what Danny said, I think that's where the relationship comes into play as well. Like we would say, the therapeutic relationship, that you need that there in order to be able to intervene, to actually reflect on something in a session that you've noticed that the mum has been saying this for months now. Every time you come to see me, it's the same thing over and over again. And you say it in your own way. It's about the relationship. I don't think either Danny, Karina or I would say it exactly the same way to every mum we work with, because it's about the relationship. You bounce off them really in terms of, I guess, language and everything, in terms of how it's going to connect with them, how it might resonate. But I think, you know, the relationship is key, isn't it? If the mum, if they're ready to hear it as well, they can actually take it in. And that can take a long time for some.
I was going to ask, in regards to that sort of when you come out of someone's house, you come out of a session, and you feel really heavy, or you feel a lot of feelings in the projections. Is that normally with someone who has sort of very complex history or history of trauma, or is it's not related to that? Is it can it just sort of come from anybody, for example? Well, if I'm asking my question right in the right way.
You're wondering whether it's a specific case, specific history that leaves you with those projections.
Yeah.
Histories. I mean, Danny and Karina might say differently. I think for me, it depends just on what's been said in the session. So it's not necessarily about their history. It's more about what's been brought up in the session. So someone just talking about something that's happened in the week, you know, regardless of their background, can be, you know, can cause a lot of feelings. Lots can be projected into you. But obviously with the more complex histories, when you're talking about some of their past, I mean, obviously, you know, Jill, we've got some of the cases we work with. There's a lot of things that can be shared that are disturbing, and things would be projected into us, which can be difficult when you're walking away from someone's house in the middle of Wandsworth or somewhere else, and you've got to dash somewhere. But
I think now, following a little bit what you're saying, what is being projected, or what the therapist or the clinician is left with, is perhaps what the patient cannot bear, is perhaps what the patient cannot think about himself or herself, and it's unbearable, it's unmanageable, and it's been just put it out there, and you may feel the sort of whatever you experience in yourself, in your body, about this communication, which is unconsciously, I don't think that intentionally the patient is sending this, is in that relationship that you picked up, that you sense something that has an impact on you, yeah? And how you stay with that, how you try to make sense what is being left with you. There was a case where a mom was actually wanting to love more her baby, and desperately wanted to feel what all the moms feel when they have a baby that she doesn't. And at some point she passed on the baby to me, because she said, "Can you hold her?" And at that point, I felt an urge in myself of mothering this baby, to taking this baby with me. There was an urge of actually having to, almost like I wanted to become the mother of this baby, very strong sense. And I was left with a sense, I think there was a communication of the mom, not only perhaps the wanting, or the baby communicating, wanting to be claimed. You know, it was a sense of, what is this about? You start wondering, where's the urge of these feelings coming from? Is it from the mom? Is it from the baby? And what do you do with that? Sorry, Danny, you were going to say something?
Oh, thank you. Sorry, I was just going to add, just on top of all those, and it was a very well worded question, actually, Jill, I thought, very well put. But I'm just thinking that some patients, but some mothers, yeah, also, I think, can make you feel quite inadequate. Some patients can make the therapist, the clinician, feel quite inadequate. And that's happened many times. And you know, I've had over the years 1 or 2 patients who've ripped shreds out of me. You know, and sometimes doing during home visits as well. One mother, I won't say too much about it, but one mother who had a very, very unexpectedly disabled baby, who was a really high flyer barrister, and her world turned upside down when this happened. And I used to go and see her weekly in her home because she wouldn't go back to the hospital because that's where the site of the trauma. And the baby was severely, severely disabled. And her anger and rage about so many things, not just about the hospital, but about probably her own self, her husband for not doing enough for her, whatever. But her life turned upside down. It was never going to be the same again. But she used to tear strips off me every week. And I had some kind of, I suppose, representation of Chelsea Westminster Hospital at that time as well. I was like the bad object. But she invited me back each week, and we, you know, we had this dynamic. But she could make me feel very, very small. But I felt I had to stick with it. But you know, goodness knows what she was feeling inside about herself. But I presume she was giving me a bit of it. She was letting me have a bit of how she was feeling. But it was, you know, I mean, you know, you get these patients sometimes who really make you feel, I think, quite inadequate through their projections and things they say. I mean, they've blatantly said things to me over the years which are quite unbelievably personal, and you think, wow, can't believe you'd say it, but they do occasionally. That can be a real heavy burden to take away with you after a day's work.
I think we are all exposed to these experiences. It's not only in therapy. I think every clinician who's seeing a patient continuously is exposed to these very powerful experiences.
Hi, Danny. If it's when you're saying with this person, was it to you as in personal and um aggressive in a personal way to you? Doesn't that cross the line to where you would have to be, this relationship can no longer be, you know, I mean, if it's just in general and the person's just venting in general, but if they're saying, Danny, you this, that, the other, I'm gonna get you, doesn't that cross the line into this is no longer a therapeutic relationship?
I suppose you've got to weigh it up, Janet. You've got to weigh it up. But generally, I suppose you try and stick with it because you know it's generally not I mean, it can be about the therapist, but it's often what's being represented within the work. It's just so I would say certainly what happened there was bordering on crossing the line as she used to behave, but I thought it was necessary to not dispatch her. It was
Okay.
important to stay with her, and you know, and she went on. You know, she's a fabulous mother to this child, but she was in a rage, absolute rage, because her life had been
Mm,
really badly damaged. And she was a
yeah.
fabulous mother to this baby, though. But
I know
but
I
I
commend you
think
for sticking with it. I'm just thinking, if it crossed the line, would you be within your rights to be, this is not, you know, you need a different therapist. I'm not the person for you.
you know that could happen in cases. I think that could happen in cases. But again, I suppose you're going to weigh it up, and you're trying to work out what's going on here.
Mm,
What's this all about? So you're always trying to tease out what's this all about at the end of it. So I think if you can work it out, well, actually, this is not really, honestly, wanting to make Danny O'Shea feel like a little midget. It's actually she needs to do it. She needs to be able to allow to be
yeah.
aggressive.
Yeah, I get that. You're a stronger person than I am.
I guess
Oh, and I
something
dread going. Sorry, and I would probably end up dreading each visit. You know, if it were,
sometimes you
I'd be
do.
like, oh God, I can't do this because she's going to be like, get in here, you slag. Do you know what I mean? I'd be like, I don't want to go. I don't want to go.
But Janet, we all do. There are patients and there are cases that we dread getting into it because we know what it's like. It's not this case. We all have had cases that you have to prepare yourself and you take a big breath because you know
For
what's
bashing.
coming.
Mm. I mean, we all know the feeling of definitely hoping someone's going to cancel,
Yes. Yes,
don't
we can
we?
all nod to that. We all nod
Yeah.
to that. Oh gosh. Okay. I mean, it's probably a deeper on a deeper level when you're a therapist, because you are exploring deep and dark places with these women, these mothers. So hopefully I get them when they're in a happier state with their baby, and you probably get them when they're not as happy.
I guess, you know, to add to what Danny was saying, what you've been saying, it's I guess I think about it like the baby who is in absolute despair and falling apart, and they need their mum, they need their parent to gather them up and to make sense of that for them in some way, or just be able to stay with it. And that's what, you know, I think is easy to think of it like in the therapy room as well. And you've got a patient that is beside themselves, whether it's with anger or upset, however, and that can come out in different ways, whether they're ripping chunks out of us. I mean, literally having sessions online has brought a whole new meaning to that. The amount of things that I've had abused in my, you know, in the background on a session or something. Usually it can be clothes, shoes, or something like that can often happen in sessions, because they build up sorts of images. But it's staying with it. It's trying to make sense of it, not retaliating, but making sense of it, giving it meaning, and then handing it back in a manageable way. Just like you'd ideally like a mum, well, in a good enough way, a mum to be able to do with her baby, that she can hand it back in a more manageable way for them to process. If that makes sense.
That's what moms do with baby. That's what we as a clinician try to do with patients. And I think, Danny, perhaps I was just thinking when you were talking about your case, it's not just, I'm thinking that it was not only the openness to receive and stay to what the patient was bringing to you, which was very powerful, but also helping to make meaning of it, to help her process. Because perhaps her anger was about the grieving of not having the child that he wanted to have. They're not going anywhere. That the family that she was expecting is not going to have it. That her life, her career, her marriage, everything has been negatively, horrendously affected. And she's angry with the world. And how
the ideal baby had disappeared. The ideal image over. No, you know, going to ballet for her daughter, etc. All of that had, you know, disappeared
having a responsive baby, a gratifying baby, and rewarding baby. Nothing of that was happening with a very severely.
And she was told many times that her baby wouldn't survive beyond a few months or something, you know, because the baby was so badly damaged. But her unbelievable care of that baby, I think, did help that baby survive.
And the ambivalence, I suppose, of this mother, trying to keep him alive, but a part of her wished that he never existed, perhaps, at some level. So hard to bear.
Yeah, absolutely. 100%.
So I think that what you were saying, that it's been there for her to be able to make sense of these very powerful meanings in terms of no one wants to hear these things or think about.
But I think you typically find as well that a lot of these cases, that they're already pre-existing issues, mental health issues already. It wasn't just about that. It was about, I think, her history too. So that came into this picture as well through the work. It wasn't just about what happened to her having this baby. It was also about other things within her personality and her history.
I'm aware Kelly's got her hand up.
Yes, thank you. That was really interesting. It's so interesting to hear more about what you do, and particularly about the practical things about how long you can do therapy for. I thought that was quite interesting. But my question is, I know you said, Danny, in your presentation about you have different styles. You all have different styles of working, and I thought that was quite interesting, because I think from, you know, the women that I go and see, a big part of what we do as nurses is explaining what therapy is and what we can provide as a service. So I think it's really important that we get the base right, like the grounding on what you do. But for me, I struggle to know the difference between what you do and what the perinatal therapy does in our service. I know that we're going to be more integrated, and you're going to be integrating into our service more. But when I have cases where I have women that are keen on therapy and I explain it to them, I'm not completely sure on what the difference is between what you do and what our perinatal therapy service provides. And I think, I don't know if that needs to be another presentation, but I think that is the key. We really do need to know the difference and what your styles are, because when we present our women that we've done assessments for, we need to have an idea of which therapy would be best. And I don't always have that. I don't know about anyone else, but I'm not clear. So that's something that I'm interested in knowing more about. That makes all sense.
Which bit is it you're not clear about, Kelly? In the which bit of the perinatal therapy is it you're not so sure about?
Well, so for example, when I go and see women, and they, you know, I'm coming up with a formulation and they're talking about therapy, it's, to me, it's not clear on which way it goes. And I know that when we have huddles, sometimes we're there and we're not quite sure. So I just think that, you know, you're saying that you have different styles, and that's really good, but it would be interesting to know what sort of styles these are, what you can provide individually, as well as what the perinatal therapy do, because I know it is different to what they provide. So and we want to get the best for our women, don't we? We want to give them the best options. So, yeah.
And I think when you say perinatal therapy, you mean perinatal psychology, don't you, Kelly?
Yes.
It's when you're deciding whether a case goes to psychology or does it come to psychotherapy.
Yes.
And it is confusing. I think it is confusing to people who have done who don't know the ins and outs of different training. And obviously, I don't think any of the psychologists are here today either to help with this conversation. But I think maybe it is something perhaps we spend some more time on at a later time when the psychologists are here as well, for them to share what they're able to offer. But they offer different ways of working. They'll do different techniques, the psychologists. I guess, you know, in a nutshell, the three of us are psychotherapists. We offer psychotherapy. We don't do other techniques. We do psychotherapy, if that's the simplest way of saying it. And it is about the relationship. It's about making sense of the past history, the past relationships, how they come to the fore in their relationship with their baby in the current time, trying to make sense of that through the relationship with each of us. And I think when Danny's talking about us all being different, I mean, add in here, Danny, he's highlighting that obviously Danny, Karina and I are very different people. We have different styles, we've got different personalities, different characteristics that will be brought into the therapy room. And we're not carbon copies of
different training background.
Yeah, different training.
Went to different training schools. I did child and adolescent psychotherapy alongside perinatal. So, you know, I've been stripped of my dignity by a lot of kids, actually, by a lot of very young children, adolescents who, you know, are really tricky. So that's another background that so I cut my teeth, if you like, alongside having the very luxury of having perinatal. Lovely, so nice to have perinatal work alongside the child and adolescent training. Very, very fortunate. But you know, I worked with very violent children who'd burst out of the room, be running around pediatric department. I'd be chasing them, you know, 50-year-old guy, whatever I was then, 40 something, running around departments trying. I mean, it's not exactly classic psych Freud. And you know, you get to work with, you know, some very, very deprived human beings. So I've been humiliated, almost you could say, by children who have been humiliated in their lives and they're growing up. So they gave it back to me in spade loads, and children of recipients of Munchausen's by proxy or whatever. So we're all bringing in our different versions of psychotherapy into this work. But I do think what I was trying to say in the piece earlier was that the thing that Karina, Melanie, I have in common, apart from the fact we like working together, and working part of this team, is that we come from a psychoanalytic orientation. That's the common denominator between the three of us. So when Mel says we're psychotherapists, we mean it. We work with people who are feeling emotional, psychological struggles, and we want them to connect with us and engage with us and have a dialogue, and we work through that dialogue in a relationship. And then we think, how do we help piece the mother and the baby together here in a mental state, in a mind state? But I'm not sure, we have to go through our own psychoanalysis for many years. So I think, Kelly, there are key differences because we come from the psychoanalytic background. So if you think someone can manage a psychotherapy that's got a psychoanalytic flavor to it, then I think, then you know where to go with your referral.
Hi, sorry. I think what Kelly is trying to say is it's not clear with regards to when we have referrals that come in, for example, where I think I understand. I understand why I would make referral to PIP, but I think it's more understanding what our psychology, what the perinatal psychology service does in with regards to what their role is in that sense, because obviously when we have referrals, so we're going to refer them for psychology, we're always hearing, oh, let's send it to PIP, but why would it go to PIP and not go to perinatal psychology? I think that's where the confusion is. Does that make sense?
Yes. And
Yes,
I think what both of you are addressing here is that, in fact, there are some differences, but there is a point where we overlap. Psychology and psychotherapy overlap. Yeah, so it's not that there is a clear cut. And I think that's what perhaps it becomes very, very confusing. So then psychologists and psychotherapists get together to discuss cases to see what would be the best. But I think that, as Mel says, we are working towards it. I mean, it would be great to have in the next meeting the psychologist, so we can have a more open discussion about this with the team. The team can ask questions, and then we can see how things fall in this bag or that bag, or will be in between. And so who will be then the best modality? What will be the best modality for that particular patient?
Yeah,
but just to bear that in mind, is there is not a clear cut.
No.
We do different things, but we overlap as well.
What would help our colleagues there with Davinia and Kelly, etc.? What would help us in future, Davinia, going forward?
I'm just concerned with when we have referrals coming on, we make a referral for either psychotherapy or psychology, it takes such a long time for the decision to be made on which team should take the client. And in the meantime, that person is dealing with their distress or trauma, whatever's going on. So I think I think it would help with just knowing what would be the time scale. Obviously we know we have our waiting list and that's fine, but it's just even just with deciding who takes on the client, it's been taking a long time. I've had 2 clients where it's taken months before, we know where this person's going. Yeah. And it's difficult when you're seeing that patient, you don't know what to say because you're still waiting for, do you see what I mean?
That you're left holding that, aren't
you? Yeah,
Virginia?
basically.
I know you've had, I know which couple of cases you're referring to, and I know that's been, it's felt like it's kind of bounced around a little bit. They've bounced around a little bit, and it's not clear. I mean,
it's just so we can give reassurance to the patient as well, because they're going to ask us every time they see us what's going on or where things are, and it's just, yeah.
I mean, sorry, go on, Natalie. You go ahead.
Yeah, just to answer a quick question around safeguarding, and I think the reason why I'm asking that is because we had a long time ago where social services wasn't doing what they were supposed to do with one of your clients, and she was having a hard time. But I was thinking about when Danny said that sometimes you adapt. You go to people's houses and you might have to sit around the kitchen. Now, in terms of safeguarding, if you have a relationship with this client and you start these sessions, you know the client, but then you went home to do a session. It mightn't be the first time, but it's probably a second time or third time. And something's not right in terms of probably the way the home is or the way mom interacting with the child. and it's more of a leading to a safeguarding issue. I just thinking, with your cap on, we know we all have a duty to safeguard, but then saying so, that could then cause a disruption in the relationship and in terms of that session, that therapy thing that you have going on. So what would you do in that case? Because bearing in mind, you know this client, and this is not the presentation, but you happen to go there and you see this presentation that, kind of a little bit worried, or you walk out the house feeling worried. In your mind, what would you do? Because it is worrying, because you're thinking, if I go down that referral route, that is it. It's disrupted. It could potentially disrupt what we have going. I was just, so from a safeguarding point of view, because I guess, when you was talking about, you've been abused by kids, I was just laughing, because when I was in my old role, we all been through this, and you got to take the abuse in order sometimes to get a positive outcome, in one sense, because, that's how the nature of the job. So just thinking in that way, how you're gonna work that out, if you're gonna go down the safeguarding and disrupt this whole nice thing going, or how you're gonna work that out.
I think, I think that's a really, really good question, Natalie, because I'm sure Karina and Danny are sat there as well, and they're thinking of cases where they've had this dilemma, where they've been aware of something, noticed something, and you are, as a therapist, very aware that to take this further means to rupture the relationship, potentially. That's going to rupture the work, that your therapy may not be able to survive, you actually raising the alarm bell, really. And I know, I've got a very vivid case that comes to mind in that respect. Was able to repair, but it wasn't easy. It really wasn't easy. You have to deal with a lot of anger from the patient through the session. It's you have to work through that again before you can get back to the work that you were doing. But there are cases it has to be done. At the end of the day, the baby comes first. If we're observing something in the home or in the relationship, I mean, that's the one that comes to mind with mine. The partner was incredibly violent, incredibly abusive towards the mum during her pregnancy, and it couldn't be ignored. It could not be raised, and it's I guess working with that. It's using things like your own, again, like we've talked about today, the countertransference, our own feelings, what is going on here, what we're observing. It's using our clinical supervision. So each of us all have individual and group clinical supervision, where we take cases and think about the process, what's going on here, using the MDT, using you guys, our colleagues, you, Natalie, call you up, say, what do we do here? What do you think? But also in the MDT, like bringing in one of the nurses who might be working with a family, or medical review, whatever it may be. I think it's about bringing others in as well, but trying to respect the therapy. It's a balance. It is a balance, and it's very difficult. It's very difficult in parent infant.
Yeah, I was just thinking that, because I know I accustomed being the body. So as a social worker, so I could take that on my shoulder and be the body,
But that's a very important. I'm just aware of the time. We're going to have to end very soon. We went over time, but I think you have raised something very important towards the end, Natalie, and it would be good to kind of keep these discussions going, because I think when it's safeguarding, things needs to be done at some point, because it's about safeguarding, but it's the way that it's going to be done is what can be thought about in a team with other colleagues, because yes, it has been tricky, but some people can maintain still the relationship despite being having to go through that process of local authorities and so on. So we have come to the end for today. It sounds like there were more people wanting to share more. Perhaps we can organize for another opportunity to have more of a discussion of all these topics, and to keep the dialogue going between us about what PIP can offer and how to understand PIP, as you say, Kelly, and and can't remember Davina that
Yeah.
they were talking about. Yeah. Thanks everyone for coming today.
We hope you have
Thank
found it useful and being able to take something from some of the things we've shared with you. We had a lot more material as well, but we thought we'd pace ourselves to see how bored you were all looking and how much more you could take. But I think you've all raised some really interesting questions, and it would be useful to continue these in some way.
It would be good to know, to get a little bit of feedback. What did you find useful about this meeting? Yeah, so we can, the next ones could be used in the best way possible. We put together something to bring up all sort of way of actually thinking about PIP, but we will be more than welcome to hear from you what you found interesting or useful or helpful in understanding and moving forward in these topics.
Thank
Brilliant.
you.
Thanks so much.
Thank you all. Thank you all for coming and chipping in with everything. Thank you.
Thank you. That was very interesting for me.
Thanks, Clotilda.
Right, so should we say bye? See you all at Christmas lunch.
Yeah.
Bye.
Bye, everyone.
Bye.
Take care.
Take care.
Bye.
Bye-bye.
Bye, everyone. See you tomorrow.
Bye, everyone.
See you tomorrow.
See ya.